want to ask all four of you a complicated question. I hope I can express it. So I want to know what the role of molecular signature is in determining what you should do in platinum-sensitive relapse. And I'm going to assume that the patient has not had Bev. I think it becomes simpler when the patient's had frontline Bev. I get it at this meeting. There's a study from Italy that shows that Bev after Bev has a 3-month improvement in progression-free survival. But the historical experience and the approval will be Bev, and then when you get platinum maintenance, you're going to get a PARP inhibitor as a maintenance. But in the patient that hasn't had frontline Bev, what role does the molecular signature play in triaging over Bev maintenance or PARP maintenance? Go ahead.
Yeah, so I think this is a great question, Brett, and we still have to kind of wrap our head around it. I tend to get somatic mutation testing on patients that have recurrent disease before I start treating. I think the information about the genomic alterations are important. Patients that have no germ mutation in BRCA1 and 2, for example, are found in about 7-8% to still harbor a somatic BRCA mutation, and therefore could be candidate for PARP inhibition.
So let me keep it, so do you use more PARP or less PARP in the BRCA patient?
I do more PARP in patients that have either a germ or somatic mutation.
Do you use more or less PARP in the BRCA patient?
I use PARP whenever I can. So if I have a platinum sensitive PRCR, I'm using PARP.
Thank you for that.
Because
and I actually use less.
I do too.
In the
Saving it.
because
You mean in terms of dose?
No, that's also true. But I preferentially triage a Bev in the BRCA patient because I can use PARP in treatment. Mm-hmm. You got one chance to use PARP in that non-molecular signature patient, and it's now. And if you don't, and she might have a durable response even though she doesn't have the molecular signature. So you got one chance. Mm-hmm. In the mutated patient, you have a chance down the road. I don't know, do you use more or less PARP in the BRCA mutated patient for maintenance in platinum-sensitive disease?
So I tend to use it in that group, and I use it in the group that is wild type and HRD negative because it's the only chance I'll have.
But you have to, if you have to make a decision between Bev and PARP,
let me phrase it this way. So for me, I look at other factors, such as do they have any significant ascites? Do they have a pleural effusion? Because I think Bev works particularly well in that area. And so I sort of look at that as being some selection bias towards Bev for me. And that's what I do. And then I tend to use more of the PARP now than Bev in that setting because I have the opposite. I think I can use Bev later on if I even I can use it again if it's been long enough, or if they happen to recur within 6 months, I can use it in the platinum-resistant setting. So I'll be able to get them Bev, but I won't be able to get them a PARP if they're HRD normal and BRCA wild type.
Go ahead, Katie.
I think I'm most similar to Tom. PARP, the 213 data really clearly showed us, I know response rate isn't as important as longevity, but it is important if you're trying to get someone to maintenance. And so you increase your response rate tremendously with Bev. So you have these high volume recurrences, pleural effusions, ascites. I'm much more likely to use Bev in that setting. I do struggle with this question that you're asking though in someone without those features and what am I picking in the maintenance setting. I like the A2, the Ariel 2 data, but I'm struck by the fact that the duration of response is only about 12 months, if I'm remembering correctly, in a BRCA patient.
In treatment.
In treatment. And if I give that patient chemotherapy and I put her into hopefully complete response, and then I put her on a maintenance, cross-trial comparisons are unfair. But if you look at any of the studies, then from the point of finishing chemo to recurrence, it's 18 to 20 months. Okay. And that sounds a lot different to me.
But yeah, I get it. But does this resonate with you that in the non-molecular signature, whether it's HRD BRCA, that responds to platinum, that if you don't use PARP now, you're never going to have another opportunity? What I'm trying to begin to brand as the one shot. You got one shot to get PARP into this patient. Does that resonate with you or not really? In the molecular signature negative patient, where Bev is an option, Do you preferentially triage to PARP because it's their only opportunity?
I mean, I hope that it's not going to be their only opportunity,
But it's
forever.
going to be, likely.
I mean, I think we have data that in treatment for biomarker negative patients that there's clinical benefit to PARP inhibitor use.
But it's not off-label, so you can't really say that.
No, I can't say that.